I'm grateful for my colleague in the law school, Lucinda Finley, for moderating the panel today. She's the Reichley Professor of Law at UB. She teaches and writes in the areas of tort law, feminist theory, reproductive rights, and the First Amendment. She previously was the lawyer for Western New York abortion providers and federal court, all the way up to the US Supreme Court, and obtained an injunction protecting access to clinics whose facilities, patients, and staff were repeatedly blocked and harassed by protesters. This injunction, which established protest-free buffer zones around clinic doorways and driveways and is still in effect today, was upheld by the US Supreme Court in a major First Amendment case known as Schenck versus Pro-Choice Network of Western New York in 1997. So I'm going to hand the microphone off to Lucinda.
Thank you, Carrie. My role here is really to introduce the speakers and try to keep them on time so that there's lots of opportunity for dialogue with this wonderful audience and amongst the panel. So our first speaker, I think the one member of the panel that remembers the days that led to the injunction and Schenck versus Pro-Choice Network and the assassination of Dr. Slepian. Katharine and I went through some of those wars together, is Dr. Katharine Morrison. A graduate of UB's School of Medicine, did her residency in obstetrics and gynecology at St. Luke's Roosevelt Hospital Center in New York City. In 1998, she started working at Buffalo Women's Services, which was one of the clinics that I represented, and performing abortions there, along with Dr. Bart Slepian. In October of 1998, Dr. Slepian, as I mentioned, who had been through years of violent protests and threats, was assassinated by an anti-abortion activist named James Kopp. Katharine continued as a provider at Women's Services and medical director, and actually was able to buy the business in 2004. In 2006, she had a chance encounter with Eileen Stewart, who's a home birth midwife, which brought Katharine to her to the radical feminism of woman-centered birth. In 2014, she opened the second freestanding birth center in New York State and the nation's only combined birth center and abortion facility, something the protesters just can't deal with. They're blocking the door. Are they blocking the woman who's going in to have her baby or to not have her baby? They just can't figure it out. Katharine's passion is exposing obstetric violence and the lack of real options most women are offered, and working towards the day when every reproductive decision is truly woman-centered. And that's what she'll be talking with us about this morning. So, Katharine Morrison. Thank you.
What I hope to show you today is that obstetric violence is unfortunately alive and well, not only in the entire United States, but in our neck of the woods in Western New York. And the maternal mortality crisis is one that has recently been well advertised, both in the regular media like MSNBC and CNN and the New York Times, and also has come into our consciousness the risk of dying when you're pregnant. But most unfortunately, even in articles like the one done in May of last year by NPR, the real underlying causes of the reason that women die in the United States during pregnancy have not been discussed. And OBGYNs, and I am an OBGYN, have been able to get away with the idea that women themselves are to blame and that what we need is more medical care and more of what doctors are doing. And I hope to show you that the problem is not with women, but with the way that they're being cared for in the United States, including in Western New York. Maternal mortality means the risk of dying, means women who die during pregnancy or a certain number of days after pregnancy. And it can be stratified into women who die because of the pregnancy, women who die because they have pre-existing conditions which are exacerbated by the pregnancy, women who die women who die who are pregnant but it's unrelated to the pregnancy, etc. But it is counted in the number of deaths per 100,000 births. So if you look at how many births there are in the United States every year, there's about 4 million births, and between 700 and 900 women die every year due to pregnancy and birth complications. And the reason that it's a little unclear is until very recently, although every time I do an abortion, I have to fill out a fetal death certificate, there was no comparable death certificate for a woman who died when she was pregnant. And in fact, there wasn't even any place on the death certificate to indicate that she had been pregnant. So the statistics were a little unclear. But that also tells you, again, who's valued in our country. Currently, our epidemic is 26 women die per 100,000 births. African American mothers die at 3 to 4 times the rate of white mothers. And in comparison, abortion mortality, less than 1 woman dies per 100,000 abortions. So every year, about 8 women die related to abortions, and about 900 women die related to pregnancy complications, either during the pregnancy or most often birth and postpartum. And the real crime of this is that maternal mortality is rising in the United States as it declines elsewhere in the world. And you may have heard in the NPR case or in the New York Times that we're one of only a few countries, sometimes they say 10 countries, sometimes they say 6 countries, in whom the maternal mortality rate is actually increasing. In every other country, it's decreasing. And this graph shows that between the x-axis is years, so between 1990 and 2015, and the y-axis is the number of deaths per 100,000 births. And then those lines indicate different countries. And as you can see, in every other country, every high-resource country, from the United Kingdom to Finland, the maternal mortality rate has gone down over those 25 years. But in the United States, it's actually gone up. And among OBGYN and the American College of OBGYN, there's a lot of debate. Maybe we weren't really counting it well before, but there is no doubt that in these other countries, they were counting it very, very well. The other thing that's very interesting is that you could also put next to these countries how much money is spent per capita on health care. And the United States is also the top. So we spend per person over $9,000, or about 17% of our GDP. And Canada, which I always love the example of Canada because it's just 15 minutes to the north of us, has a maternal mortality rate that's between 25, is either a quarter or a third of ours, and they spend less than half as much per person, and maybe 9% of their GDP on healthcare. So when you talk about the possible causes of maternal mortality, I can tell you it's not due to inadequate resources. We spend over $100 billion per year on on maternity care, and maternity and newborn care is the single largest category of insurance payouts to hospitals, both private insurance and Medicaid. If you ask the American College of OBGYN, of which I and Dr. Parrott are members, they will tell you that there are many problems that have led to the maternal mortality crisis in this country. And let me tell you, it's all our fault. And by us, I mean women. Mothers are getting older, we have pre-existing medical conditions, we're fat, we abuse substances, we don't get enough prenatal care, and the only thing that they think that maybe OBGYNs might be responsible for is that when there are complications, we don't have a standardized way of addressing those complications. And again, most unfortunately, when you listen to any of the programs on the maternal mortality crisis, or I brought with me one of the OBGYN throwaway journals, you can go from start to stop in these articles or these talks, and there will be nothing there about the many real reasons why women are dying, because they are all related to the way obstetrics and gynecology cares for women. So here are the unaddressed causes. The cesarean section rate. So the World Health Organization says that the ideal cesarean section rate is between 10 and 15%. Below between 10 and 15%, women and babies die. But above 15%, babies are not helped, but women are harmed. The World Health Organization has been saying this for about 30 years. The cesarean section rate in the United States in 1970 was 5%, but in 2015 it was 40%. The risk of dying from a cesarean section is 4 times that of a vaginal birth. So if you have a cesarean section, you have 4 times the risk of dying that you would have if you had a vaginal birth. And at the same time, not between 1970, but between about 1996 and now, inductions, that is, women who are pregnant but not in labor, but their labor is brought on, the induction rate increased from 9% to 25%. So if you go to a labor and delivery unit, 1/4 of the women on the board or the computer screen who are in the hospital on labor and delivery are being induced. An induction increases the risk of a cesarean section. So why so many cesarean sections? Well, in the 1970s, a monitor was created called the Continuous Electronic Fetal Monitor. And the idea was that labor was somehow dangerous to babies. So the uterus, that only the uterus can grow a baby, but the fear was that the rhythmic contractions that cause the cervix to dilate and push a baby out through a small hole were somehow dangerous to a baby. And that if we did a continuous monitoring of the baby's heartbeat, we would see which babies were somehow being compromised by labor, and we could, quote unquote, expedite labor. And in the 1970s, that meant forceps, so putting spoons on the baby's head and pulling it out. And then increasingly it meant a cesarean section. And the idea behind the continuous electronic fetal monitor was that we would be able to prevent cerebral palsy, that the contractions were powerful, deprived the baby of oxygen, and if we prevented labor, then we could prevent cerebral palsy. But in the past 40 years, the rate of cerebral palsy among full-term infants has not changed one bit. In fact, it's quite low. It's 1 to 2 per 1,000 full-term babies. But the cesarean section rate has skyrocketed. And in fact, the continuous electronic fetal monitor in many many peer-reviewed studies, has been shown to have zero positive predictive value. And by that, I mean zero positive predictive value means if you had a fire alarm and every time it went off, you could be guaranteed there wasn't a fire. That's what that means. So every time the fetal monitor says that the baby is in trouble, statistically, it is wrong 100% of the time. And even the American College of OBGYN has put out many position papers saying that intermittent auscultation, which means listening to the baby every half an hour, is equal to or superior to continuous electronic fetal monitoring, yet it does not recommend removing the continuous electronic fetal monitor from many hospitals. So the American College of OBGYN does not recommend removing this device, which has been shown to be wrong 100% of the time. And in most hospitals, the continuous electronic fetal monitor has been universally accepted, and in every maternity ward in the United States, when you check in, you are put on the continuous electronic fetal monitor. Inductions. The American College of OBGYN recommends induction between 42 completed weeks of pregnancy and 43 completed weeks of pregnancy, yet it permits any induction after 39 weeks. Inductions increase the risk of cesarean section. The continuous electronic fetal monitor increases the risk of cesarean section, but the American College of OBGYN, which is tasked with protecting women, actually has nothing to say about these two items, which are the reason that so many women are dying. The National Institutes of Health did two exhaustive studies, one in 1990 and then more recently in 2010, that vaginal birth after cesarean section is safer for women than repeat cesarean sections. But the American College of OBGYN policies are written specifically in such a way that hospitals are allowed to forbid the safer VBAC. And in our own area, there are hospitals, for example, WCA in Jamestown and in Olean, that do not permit a woman to have a vaginal birth after a cesarean section and force her to have a cesarean section. And this is the only situation in all of American medicine where a competent adult is forced to have an operation. ACOG studies show that women given more time in labor can achieve a vaginal birth, that they can safely eat and drink in labor. The same studies show that doulas, that is a birth assistant, can improve the vaginal birth rate and patient satisfaction, but but ACOG permits hospitals to set an artificial time frame on how long you're allowed to be in labor, allow them to forbid food and drink, and allow hospitals and physicians to forbid doulas. The American College of OBGYN also has position papers and political action groups to prevent home birth. Although in those same papers they say, we recognize that it's a woman's right to decide where she wants to have a baby, but she absolutely should not have a baby at home. They've put a lot of energy into forbidding water birth. They just came out against vaginal seating. They prosecute lay midwives, although each one of these has been shown to have a lower maternal mortality rate than standard hospital birth.
You want to know what vaginal seating is?
Some women who have cesarean sections very much want the baby to get the microbiome. We were designed to traverse the vagina and to get the bacteria in the vagina. And mothers who have cesarean sections, some of them want the babies to have that advantage. And so they ask to have some gauze wiped from their vagina, and then after the baby is born by C-section, to wipe the baby with that. But the American College of OBGYN has come out against it, saying that there are a lot of bacteria. So in Western New York, hospitals and physicians are free to set unscientific and coercive policies, mandating the continuous electronic fetal monitor, mandating IVs, mandating no food and drink, setting limits on how long a woman could be in labor. They are free to refuse a safer VBAC and to insist on a repeat cesarean section. And consent forms in a hospital, which I have admitting privileges at, has both, I consent to have a vaginal birth and episiotomy and a cesarean section. And so, as the woman walks in labor, she has signed away her rights to refuse a cesarean section. These are the policies that are killing women. And so when you hear about the maternal mortality rate, please don't think that the important thing is to get more OBGYNs into the community and to get more prenatal care for women. In our area, we are fortunate to have a large Amish community. And not only do they not go to doctors, they don't go to certified nurse midwives. Eileen is a certified nurse midwife. They have lay midwives. Their maternal mortality rate is one of the lowest. And believe me, the best thing that could happen is if people would call out the American College of OBGYN for their coercive and destructive policies to women. Other options: home birth with a nurse midwife or a lay midwife, free birth, which means having your baby without an attendant, low intervention hospital birth. We have a freestanding birth center. Our patients are wonderful patients, but they're no more special than anybody else's. But utilizing intensive education, doulas, and the concept of patient ownership, we have a vaginal birth rate of 88%, so only a 12% section rate, a VBAC rate of 85%, it's only between 6 and 11% at area hospitals, and 95% of our babies are fully breastfed. We also have a different model where the doctor is not the head person, but we have shared responsibility and decision-making between patient, doula, birth assistant, and myself. I want to make the connection between abortion access, abortion rights, and birth rights. Not just because I do abortion 2 days a week and birth whenever it happens, but because the woman who's having a baby and the woman who's having an abortion are the same woman at different points in her life cycle. Anti-abortion laws are used to deprive women of rights in pregnancy and labor, to incarcerate women, such as the Wisconsin unborn child rights law, which led to women being incarcerated so that they wouldn't harm the child that they were carrying, and coercive birth policies. If you are completely focused on the fetus and you think that the baby's the only thing that matters, then the woman is just a vessel and she has no right to make decisions about her own body. And it's those practices that have led to women having C-sections they didn't want, inductions they didn't want, and being harmed. We know that one of the main things that decreased maternal mortality in this country was Roe. When you ended illegal abortion, when you had access to safe legal abortion, the maternal mortality rate dropped. When you decrease access to abortion, you don't decrease abortion, but you increase maternal mortality. And decreasing women's input into their own birth increases maternal mortality. And remember, it's her body, it's her uterus, it's her baby.